now for our main discussion. On the line, we have Dr. David Lam, legislator from the Medical and Health Services constituency, and also Dickie Chow, Head of Healthcare and Social Innovation at the Our Hong Kong Foundation. Good morning to you both. Dr. Lam, perhaps we could start with you. Good morning.
Good morning.
So what do you think about this proposal to increase the charges for people visiting A&E departments when they don't really need emergency treatment?
Now, we are talking about a possible so-called abuse of the emergency department by some of our residents in Hong Kong. So, like talking about someone who goes to the emergency room, wait for 7 hours to treat for a minor condition. Who would do that, waiting for 7 hours? It's probably very, very few people would really kind of abuse the system that way. More often, we have people who think who genuinely think that the condition is urgent and serious. That's why they go to the emergency room. And very often, it happens outside office hours where they have little choice. Now, so before you increase the fee of emergency departments, we must make sure that our residents in Hong Kong have a choice, have an alternative. The choice is there in the daytime. They can go to the family doctor. They can go to the general outpatient clinics in case they belong to the underprivileged. But what about in the middle of the night? If you have no choice, people will just come, pay more, wait 7 hours, receive that treatment, and it benefits no one. And if you look back into history, when we last increased our emergency room fees, has there been a significant drop in the number of attendances? It doesn't seem so. So first of all is why are we trying to increase the fee? If that is to lead to a better triage of patients so that someone who finds themselves not in a dire condition can go elsewhere, then first of all, start with giving them a choice and letting them know they do have a choice. And thirdly, supporting the community with doctors and other people there so that they can provide a service such as they can have access to, say, a subsidized blood test, subsidized X-rays, which is the case in the emergency room.
So would that involve like an improved triage system? Because at the moment, patients go to the emergency room, they're put into one of 5 categories, isn't it? I mean, would it also be possible to advise somebody if they don't need urgent treatment, if they can, come back the next day or go to an outpatient clinic or something like that?
They are doing that already for many, many years. So people are triaged, and then the triage nurse will tell them, hey, sir, you belong to category 4. That means it's not really urgent. And if you don't want to wait 7 hours, 8 hours, you can go to your private doctor, your family doctor, or what about the general outpatient clinic? Now, the problem here is that our general outpatient clinics are always full. Just full to the brim. So overflow cases go to A&E. Now, if you think about it, it doesn't make sense. We're talking about when our primary healthcare system overflows, the patients go to a secondary or tertiary healthcare system. It doesn't make sense. So what we need to do is to increase the capacity of primary healthcare, not necessarily the GOPC capacity alone, but the entire primary healthcare. That's why we are promoting primary care doctors or family doctors. But then they do not have enough support as you have in the emergency room. What about if a patient needs a blood test? If you go to the private sector, you have to pay full fee. But what about if it is subsidized by the government? Partly. Of course, now I'm not saying the government should subsidize everyone for the blood test. No, definitely not. Subsidy should be according to necessity. If you look at the chronic disease co-care program rolled out by the government recently, it subsidized everyone above 45 years of age. Well, this is one way of doing things. But if you want to fine-tune it, you can actually subsidize only those who apply for a subsidy. And when they apply for the subsidy, when they say they register for the family doctor, then there should be a kind of an assessment And of course, if they are already on other subsidy schemes, then you can waive that assessment. So in that way, we can really divert our valuable resources to those people who need it. And in the community, we can provide a lot of services, a lot more services, if such subsidy is well used and directed to those who really need it.
Dr. Lam, your view is that increasing these fee hike proposals isn't really going to deter people from A&E. But then the government is thinking about it quite seriously. So what's driving them? Is it merely just to fill up the Treasury coffers?
No, I don't think so. It's really not about cost recovery. The average cost of an A&E attendance is like 2,000 Hong Kong dollars. And if you increase the attendance fee to like $400 or $500, it's still far away from cost recovery. It is really a way of trying to triage people better. As I just mentioned, we need a choice. If people have a choice, then they can go elsewhere. In the daytime, it makes sense. It makes sense because if you go to see the A&E doctor, you have to pay $400, and if you go to see a family doctor, maybe $350, and you don't have to wait, then there may be a better way of diverting patients to see the family doctor. But another issue that is not really touched, but it's also a cost issue, is what the patient receives at the emergency room. I've asked an emergency room consultant some time ago how many emergency CT brains do they do in one single day. The answer is 80, just for the A&E. Now, there are 400 attendances per day in A&E. Half of those are classified as non-urgent, so we're looking at 200. And out of the 200, not all of them have had injury, but you have 80 CT brains a day. Is that too much? There's too many, definitely. So why? There are lots of reasons behind it, but if you add in a co-payment system for people who doesn't fall into, say, a protocol for head injury, then they have to pay a certain amount of fee, like $500, $400. Then that deters people who doesn't really need that CT brain to ask for a CT brain. Now, but that comes to a protocol issue. You need a protocol for head injury. If someone falls into the protocol, they receive the CT scan at no extra charges. That's what I propose. But if someone who doesn't fall into that protocol and they insist to have a CT scan, then you pay extra, so a co-payment. Now that kind of will deter people from misusing valuable resources in the A&E. It's something we can further think about, rather than to say put a cutoff. If you are category 4, then you go to see, you pay more. Now that is not really a very good way of doing things, because you put the burden on the frontline nursing staff who does the triage. And triage is not the full consultation, so it's always not 100% correct.
Sure.
But if you increase just the daytime attendance to something similar to private sector, well, that's arguable. But yes, in the daytime it may help, but in the nighttime you must give people a choice. And if you talk about what is the average fee of seeing a private doctor in Hong Kong, again, that's a wide range. If you go to the public housing estate, nowadays, maybe like between $300 and $400, including 3 days of basic medicine, which is not expensive compared to the rest of the world with a similar standard of care. But if you talk about someone, say, in the central, that may go up to $1,000 or more. So it's also a wide range.
Okay. All right. Well, thank you very much, Dr. Lam. I understand that you have to leave us now. You're going to be with us till 9:15. But thank you for your contribution. That was Dr. David Lam, legislator from the Medical and Health Services constituency.